Welcome to Always Home Care COPD Caregiver Training. COPD is a very common disease within the elderly population, and therefore it's important for caregivers to understand what the disease is, what it's like to work with a client who has COPD, what medicine they may see that client taking, and when to get medical attention for someone who has COPD. I'm Mark Rosny, Certified Senior Advisor and President of Always Home Care, and joining me today is Dee Pettinger, Registered Nurse and Masters of Public Health.
Chronic obstructive pulmonary disease, otherwise known as COPD, is the most common lung disease diagnosis. Typically, it makes it difficult for patients to breathe and encompasses both chronic bronchitis with a long-term cough and a mucus buildup, and emphysema, which is actually the destruction of the lung's parenchyma over time. Caregivers need to know that COPD and depression go hand in hand, and it's thought to occur because a patient feels breathless, and that makes them avoid activities like walking, playing with the dog, taking the grandkids to the park, that make them feel breathless. When they do less, their muscles weaken, which then increases the breathlessness. They end up becoming depressed because they're not able to do activities that they enjoy. So when you have a patient who is diagnosed with COPD, try and make sure that they're included in activities, or that you find out what they enjoy so that we can work together to find ways to continue those activities. The medical team for COPD patients will consist of both a primary care physician and a pulmonologist, who the patient will typically see when they have developed a pneumonia or they become unresponsive to antibiotics. The pulmonologist, who is very specifically a lung doctor, will see COPD patients when there are changes in their disease, or quarterly. They do need frequent checkups to make sure that there are no continuing destructive changes in the lung tissue. So some common treatments for COPD that are non-pharmaceutical are chest physiotherapy, which is positioning to maintain proper drainage from each of the lobes of the lung into the throat so that a patient can cough up the mucus. And you'll see on the right a number of diagrams. Our upper lobes by our collarbone obviously drain pretty easily, but it's the lower lobes that patients often have a hard time clearing. You will also see the team often consist of pulmonary rehab, exercise, nutrition, and disease management. And those people are not always part of the treatment. On an ongoing basis, they're often included when the disease is first diagnosed, and then to manage any changes in a patient's condition. So more commonly, you'll also see lung volume reduction surgery, and if you hear that your patient has had this or is going to have this, what you need to know about it is that it essentially removes dead tissue in the lungs. What that does is frees up space in the thoracic cavity, which allows the healthy lung tissue to expand, and it ensures that inspired air is actually directed to the functioning lobes so that oxygen can be absorbed into the capillary system and that carbon dioxide can be expelled. Additionally, patients are often taught how to pursed lip breathe, and you'll see that in the diagram what that consists of is simply inhaling through your nose as if you're sniffing for 2 whole seconds, Then patients are taught to purse their lips like they're blowing out a candle, or they're going to whistle and blow out the air slowly. You should instruct patients to breathe out twice as long as they breathe in, and that's pursed lip breathing. The purpose behind pursed lip breathing is that patients with COPD have a very difficult time expelling carbon dioxide, which sets them up for other problems. So we want to make sure that they have enough time to expel the carbon. So oxygen use is very, very common in COPD and in any of the lung diseases. Couple of things to consider. Of course, you probably know this, but oxygen is extremely flammable. You have to keep it away from any heat source or flame. Patients should not be around anyone who smokes. And it is actually considered a prescribed medication. So our caregivers are not under any circumstances to change that flow rate. So the reasoning behind me emphasizing that oxygen use is a prescribed medication and that you are never to adjust the flow rate, even if a patient seems breathless, is that a patient with COPD does not have the same mechanism of breathing that you or I would. And in fact, typically in a healthy patient, an increase in carbon dioxide is what triggers the next breath. In a patient with COPD, it's actually a lack of oxygen in the blood. By increasing the flow rate, you fundamentally alter what the brain perceives as the level of oxygen. Although, in reality, the patient does not have that level of oxygenation. So we are preventing the natural desire to take a breath. So one of the most common medication types is a long-acting beta agonist. And what that also is referred to is a LABA. A LABA is essentially a bronchial dilator. It is not a rescue medication. They're traditionally prescribed once a day, occasionally twice, depending on the severity of the patient's condition. What you need to know is that you must make sure that the patient is taking these medications after they take their steroid. They need to wait 5 to 10 minutes, which allows the steroids to get in, open the lungs, and then the beta agonist can go to work. Other common medications are steroids. You might see Flonase, you might see Qvar, Arabid. Those are all very common. And frequently we are now seeing a combined medication, which is the Advair Diskus, Symbicort, or Dulera. After each of these medications, any of the inhaled drugs, you need to have the patient rinse and spit. So these drugs are most effective when taken consistently, and again, it's either once or twice daily as prescribed. And when the patient is using the 2 inhalers, again, make sure that the patient uses the steroid 5 to 10 minutes before they use the LABA. Some other common medications, you might see Spiriva, which is typically 1 puff daily in the morning. And again, you'll want to ensure that the patient takes this after steroid use. You may see Atrovent, which is typically 4 puffs. So you may see patients, that are prescribed QID or 4 puffs daily. And we can help them out by doing an 8 a.m., 2 p.m., 8 p.m., 12 p.m. It is not necessarily needed at 12 p.m. You can do one, at 8 a.m., noon, 3, as long as they're getting those 4 puffs daily, and then they can take the last puff prior to bed. And of course, patients with COPD are oftentimes on antibiotics when they come down with an illness, and we have to make sure that they are taking their antibiotic as directed, and that we're helping that patient ensure hydration, because oftentimes antibiotics will cause a little bit of diarrhea and force them to be a little dehydrated. The other thing that they do is antibiotics often kill good bacteria in the gut, so we can help them stay healthy and well by having them eat things like Greek yogurts, anything with a live, active culture. Other medications may be used, and you might see opioid medications. These can be like the Oxycontins, the morphines. Painkillers actually decrease nervous stimulation, and what that does is just help relieve that feeling of air hunger when the oxygen is low in the body. And it is very normal to see these in late or terminal stage illness.
One more comment about the information about all the medications. This information is presented here so caregivers have an idea of what a COPD patient would typically be taking and the typical dosage regimen that would be recommended by their physicians. Of course, our role is to remind our clients to take their medicine when they're supposed to.
We can also help ensure that patients remain current on their vaccines. Pneumovaxes and flu vaccines both help prevent COPD patients from falling ill, and therefore increase quality of life and life expectancy. Policy note: caregivers with COPD patients must never go to work when ill with a respiratory infection. So there are some lifestyle changes that we can help patients make to improve health and quality of life. We can make sure that patients track their medications, the time, the dosage, and any side effects that we're noticing or that they're experiencing. We can work with the patient to maintain daily activity, simply keeping the body healthy, keeping the lungs healthy. That diaphragm is a muscle, and if we don't use it, it will lose its ability to function properly. We can work with a patient to quit smoking. There are a number of things that we can do as caregivers to support that. And you feel free to contact me if I can help. And of course, we can make sure that patients are current on their vaccines to avoid any illnesses that complicate a lung disease. We need to ensure that we talk to doctors or pharmacists on behalf of our patients before a patient begins taking any cold medication or over-the-counter medication. And this is simply to ensure that there are no interactions. We need to keep an eye on the emotional health and talk to your doctor if our patient's depressed. And we need to ensure that we limit airborne irritants such as insecticides, hairsprays, any aerosolized product, because it can irritate the lining of the bronchus and the tissues of the lungs. In nutritional considerations, consider preparing foods with herbs and no salt spices to add flavor. Avoiding salt is key. Salt actually increases water retention, which can make breathing difficult in patients with COPD. So read labels and avoid foods with anything more than 300 milligrams of sodium per serving. And check with the patient's the physician or the nurse before you use a salt substitute. Some salt substitutes contain other ingredients that can be just as harmful. Some other helpful hints are to eat a balanced diet with a rainbow of colors, maintain good fluid intake, control the salt. And to do this, we can assist patients by taking the salt shaker off the table or not bringing it to them when we serve meals. If we note that our patients are having difficulty breathing during eating, we can make sure that they're clearing their airways thoroughly before we serve a meal. So about an hour, take them through some inspiration techniques, or if they have the little flow meter, we can encourage them to cough. We can encourage them to tripod, which is to lean forward onto their knees, which all helps and assists in clearing the airway. We need to make sure that they eat slowly, taking small bites and chewing thoroughly, and breathing deeply. And believe it or not, simply putting down the utensil between bites can help them regulate how fast they eat and prevent choking and some other distressing symptoms. We need to help them choose foods that are easy to chew. And we can serve 5 or 6 small meals a day instead of 3 large ones. Those large meals tend to put undue pressure on the diaphragm, making it difficult for a patient to take a deep breath. If we notice our patients are short of breath after eating, you try drinking liquids at the end of the meal instead of drinking before the meal, which can make them feel bloated. We need to eat while sitting up, and again, that tripod position where a patient is sitting, slightly leaning forward, as if they were on a third peg, so to speak. And you can assist them in doing that by having a table in front of them, something stable to lean forward onto. And of course, we can help them by reminding patients to continue pursed-lipped breathing technique. So there are things that a caregiver may see that should flag an immediate call to the doctor. Increasingly difficult breathing, wheezing during usual activities. If you see an increased cough, increase in mucus, or chest pain while coughing, any mucus that's bloody, has a foul odor, and is starting to turn green or yellow throughout the day, any of these things should prompt a call to the primary care physician or pulmonologist. We need to monitor our patients for swollen hands, ankles, feet. If they are increasingly fatigued and not able to respond, they start noticing muscle cramps and weaknesses, any shortness of breath that interrupts sleep, and of course, anything that the patient reports that is new and impacts their life in a distressing way, we need to let the physician know. That is something that oftentimes can be monitored, can be changed very simply, but they do need to know. For more information, you can contact the COPD Foundation, and the website address is given, and you can also contact the office and relay any questions to myself. Thanks so much for your attention. Have a fabulous day.
And if you have any additional questions after reviewing this recording, please email training@alwayshomecare.org and we will get your questions answered.